Hi guys, welcome back to the Adaptive Zone podcast. My name's Matthew Boyd. I'm a physio and running coach, and today we're going to be talking about patellar tendon pain in runners, and we've invited quite the expert on the show today. I'm quite excited. We have, is it Professor or Dr. Peter Malliares? I'm afraid I'm not sure.
Professor. Yep.
Professor Peter Malliares from in Melbourne, and he is, I would say, one of the world's leading experts on tendon pain. So Professor Malliares, thank you for joining us on the Adaptive Zone podcast.
Thank you very much, Matthew. Thanks for having me.
And so, could you tell us a little bit about yourself and your professional work?
Yeah, sure. So I basically am a physio. I have been working as a physio since 1998, and I work clinically in a clinic where I see a lot of tendinopathy patients, and I also work at a university where I do research in tendinopathy, and that university is Monash University at the moment. And I supervise students, and we have a lab, and we do research there. So I see a range of patients with tendinopathy, mainly from the lower limb. So that's pretty much me at the moment.
Okay, so what got you interested in specializing in? Actually, we should qualify that. What you mentioned tendinopathy a couple of times. Could you explain to us, like, very much just like a basic explanation of what that is?
Yeah, so tendinopathy is a condition that is characterized by pain, persistent pain, usually around the tendon, and also dysfunction or disability. And it also underlying, if you look into the tissues, into the body, you also sometimes see that there are changes to the tendon, to the tissue, and we call those pathology. So that's a sort of what we define as tendinopathy these days. It used to be called tendinitis. Some people still call it tendinitis. It's probably not recommended, but it's a common lay description of what it is. We don't tend to like that term as much because it infers that there's an itis, which is inflammation, which is not necessarily true, or we don't have the certainty about what is the underlying pathological process, so we don't recommend using that term. So tendinopathy just means general pain and a bit of disability or dysfunction around the tendon. So for example, for runners, they'll get patellar tendon pain, and they'll also get maybe some dysfunction in terms of their running. Maybe they won't be able to run as well, especially when they're doing things like hills or faster running. So that's basically tendinopathy.
So if a runner was wondering if they had tendinopathy, they would need to have pain located around or within the tendon, which is just below the kneecap for the patellar tendon. And they would also need to have what you call dysfunction, which is the loss of ability to do certain things, like, let's say, run as much as they want to. And if they have those two things, would that suggest that they have patellar tendinopathy?
The diagnosis is actually quite complex, but yes, that would be the right path that they're going down. So the diagnosis, so if you wind the clock back 20, 30 years, diagnosis was just imaging. So we used to think that if you had an ultrasound or an MRI showing that you've got some pathology in your tendon, then that's basically enough to diagnose this painful condition. Now we know that, and this is a hard thing for a lot of patients to get their head around, pain is not necessarily present when people have tissue changes like pathology on scans. And it could be that you've got these, well, a lot of runners have tissue changes in their tendons but don't have pain. And that's pretty normal, and we accept that, and especially as we get older and we keep being active. So So I think now the diagnosis is, as you say, much more clinical. So it's about where the pain is, it's about what aggravates the pain, it's about ruling out other types of conditions that can cause it. So it's a bit more nuanced, but it, yeah, definitely is more of a assessment diagnosis. So it's based on the questions and the physical test that, say, someone like a physio, sports doctor would be able to do if you visit them.
So if someone did have an MRI and it showed, like in the description that the radiologist gave, it said that there are evidence of tendinopathy on the scan, on the MRI or ultrasound. If it doesn't hurt in that area, then you wouldn't necessarily say that that person has a tendinopathy because they don't have any symptoms of it. Is that right?
That's correct. That you wouldn't say they've got a painful tendinopathy. You could say they've got tissue changes in the tendon, but they haven't got a painful tendinopathy.
Yeah. So in order to sort of have the condition of patellar tendinopathy, you really need the patellar tendon, which is that tendon just below the kneecap. That needs to hurt when you're doing stuff. Is that right?
That's correct. Yeah. So painful tendinopathy, then you will have the pain with it. Some people call tendinopathy. Some definitions of tendinopathy include just tissue changes. So you've got to be careful to say, the diagnosis is painful tendinopathy or symptomatic tendinopathy.
So
Sometimes we call it symptomatic tendinopathy and asymptomatic tendinopathy to distinguish that some people do have still tendon changes, which you still can call tendinopathy, but they're not painful.
right, okay. So you just want to be sure about what you're talking about, and the fact that you have these changes isn't necessarily such a bad thing. If it doesn't hurt and it never has hurt, then it's not necessarily something to be too worried about, or is that
Yeah,
not
that's
correct?
exactly right. That's exactly right. So and I guess going back to the definition and what tendinopathy is, we know that it's a load-related problem. So it's most likely for most people related to activity over time, especially changes or sudden changes in activity. So generally, if you're careful with how you change your activity over time, and you're not doing things that are really out of the ordinary and changing your loading very suddenly. So, for example, you go from running 10 miles to say, 50 miles within a month or something per week. Then you're managing the risk of things getting much worse for you. And in that case, if you've got a bit of asymptomatic pathology there, usually it's very, very stable over time. It doesn't change. It just stays the same. It doesn't really change much at all.
So if a runner was wondering if the pain that they have in their knee is patellar tendinopathy, like how might they know?
They So basically, are you asking how a runner would actually differentiate whether it's patellar tendon or something else?
Yes.
Okay, so basically they would they generally probably the easiest way is to look for very, very, very localized pain. So if the pain is very, very localized to that kneecap, the bottom of the kneecap area where the tendon joins the kneecap, that is usually very likely to be a patellar tendon problem. Now, one of the things for runners to note is that it's actually much more common to have pain that's coming from the kneecap rather than pain that's coming from the tendon itself. It's much more common to have that for runners. Usually we see patellar tendon in more likely sprinting or jumping athletes. So, if you're running but you're doing a lot of sprinting or hill work, you may get patellar tendinopathy, a lot of speed sessions. If you're a sprinter, then it's much more likely. If you're a jumping athlete like a volleyball, basketball, it's much more likely. But it's actually quite uncommon for just the recreational runner who just doesn't do a lot of intensity in running. You don't tend to see patellar tendinopathy in that group very much. And that's where you start thinking, is there something else going on? Even if the pain is localized to that inferior, to that part of the kneecap where the tendon joins, you still start looking for other diagnoses.
What would be other things that... So when you say localized, just so we keep the listener on the same page, what exactly do you mean by localized?
So localized would be, if you're looking at a picture of the front of your knee, you see the kneecap and then you see the tendon joining it at the bottom. It'll be an area of pain that is 1 to 2 centimeters across the bottom part of that joint. So quite small area of pain. So with patellar tendon, you don't get it generally referring or sometimes going into other areas. You don't generally get that with patellar tendon. It stays very much on the same spot.
And so that would contrast with, say, something that was more like vague or diffuse, like a generalized pain around the knee. It's like you can kind of point to it if you've got a patellar tendon pain. You're like, it's right there. It's not like somewhere around here. Is that
exactly
what we're getting at here?
Exactly right. Yeah, exactly. That's correct. That's a good way to describe it. Yeah. Yeah.
And you say it's not common in distance runners. So if someone's listening to this podcast and they have pain in that area and it is small, but they are more of an endurance runner, so they do most of their mileage at quite a low intensity, and they're not doing a lot of hill sprinting or any sports involving jumping like basketball, do you think that it's possible that they have patellar tendinopathy, or do you think it's so rare that it's almost certainly not? I know it's a difficult question to be specific about.
No, it's possible. It's possible. Sometimes they'll have other predisposing factors, like they might have had some surgeries around the knee, or they might have had Osgood-Schlatter's disease, which is the growing disease around the knee when they're young, and those things may predispose them to developing a patellar tendon, even if they're doing what we would classify as lower load activities, like say distance running, as opposed to sprinting or running up hills or some more intense type knee loading activities. Because the knee loading with just endurance running is actually quite moderate compared to what you would get with sprinting and other activities, where the patellar tendon is much more active and contributing to those movements.
So perhaps if, like, a lot of runners will do like a lot of slow mileage, but then they might have 1 or 2 days a week where they do like a track workout or hills and stuff. And if their knee pain is quite localized, so small, just below the kneecap, and it's particularly problematic with those type of higher intensity runs, then it's maybe more likely that it's the patellar tendon as opposed to something else.
Yes, exactly. Yep.
Okay. And so if that does describe someone's issue, and maybe they've had this, like, how long does this persist for? Is this something that sort of self-corrects quite quickly, or does this last for a long time? And how does it behave?
It is a difficult problem. So it's a really, really difficult problem to overcome. And it can be long-lasting. It is difficult from point of view of it can last for a long time. So generally, when people have it, they tend to have it for a number of months, and especially if they want to go back to high loading activities like intense running, it can be really, really hard to overcome, because you need to develop the appropriate type of ability to do those activities with minimal or no pain, and that becomes really, really difficult and challenging. So it is a hard problem to overcome, and it requires a lot of perseverance on the part of the person who's got it to be able to implement a treatment plan that's going to get them better.
And so it might be that someone with this problem can run quite a lot, but they have trouble with those higher intensity runs. just
Yes.
specifically that, but then and then that might go on for a long time, like months or years. So they're still running, but anytime they really try and push the envelope on speed work, they have trouble.
Yes, exactly right. Yeah, exactly right. So they might be, yeah, they might be okay with a lot of things, but once they start to do speed or hills, some more intensity, that's when they start to get the pain. And usually the pain manifests, usually it manifests as pain with very high loading activities like the speed work. It could manifest at the start of the speed work and then warm up, or sometimes it presents at the end of the speed session. Sometimes it's fine during the speed session, but it's the next day that people feel it. So usually that's right. It's the higher intensity activities they'll feel it with.
Okay. So if someone's, maybe they've had a diagnosis from a doctor or a physio, or they're pretty confident listening to this that that's what's going on, like, how would someone address that problem?
Okay, so basically, um, the the main first line treatments that we offer are things like um, trying to investigate what are the main causes. So usually it's some sort of, improper loading, loading too much, overtraining, doing too much intensity, not transitioning to the higher intensity gradually enough. So I think the most important thing is understanding how they should be loading. And as part of that, also reducing the load in the short term to make sure that they are not aggravating or continuing to aggravate the problem. Um, and then the next major part is exercise to improve the strength and bring about some more ability to do the higher load, intense type activities. So that would be the next part of it. So that usually a combination of those two things usually is enough for most people. It does take time, as we talked about, so it might take 4 to 6 months, and you sort of look for short-term gains like reduction in pain or improvement in strength during that process, but it can take a long time, and then gradually returning to running higher intensity. For some people, they need additional things, like, for example, probably the key, most common ones that are offered for these types of tendinopathies are things like if you go and see a physio, they might do some taping or some manual therapy, um, or you could also go to other options like there's something called shockwave therapy, which is a treatment used, but also then there's things like injections, a whole range of injections that people offer. What probably needs to be said about all those is that the evidence for all of those is not very strong. The evidence for exercise is probably stronger, but again, is still something that we are developing.
Okay. So would you say, in your opinion, the exercise is the way to go based on what we know currently, just in terms of the sort of current body of evidence, that you would suggest that first and foremost work on exercise-based treatment rather than pursuing those other things that you mentioned?
Yeah, I would say so. I think that's accurate. Yep.
And in terms of, could you give us an example of what that might look like? So let's say we had a 35-year-old runner who's doing maybe 50K a week and they have trouble with faster runs. So when they're doing hill sprints, for example, they can't finish their workout because their tendon is hurting them. Like, you said that you've got to create a situation where the capacity of that tendon is such that it can handle those loads, and it might take a few months. Like, what would that person need to actually do? Like, what would be an example of it to get them
Yeah.
to that point?
So, usually at the start, you need to gauge what their severity is and what their ability is to take load, and then based on that, you might give them advice about reducing in the short term things that are probably keeping on aggravating the problem. So it might be that they reduce their running in the short term, but then you would then generally get them onto a loading program where they try and over months do things that are heavy loading, usually for the knee, like it could be they're doing squatting or They're doing some other forms of knee loading, leg extensions, leg press, step ups, a whole range of things that we tend to offer in a way that we bring them in when the person is able to tolerate them, and you increase the loading, you get to very intense loading. So generally, repetition ranges of say 4 to 8 repetitions. So they're before they reach not necessarily reaching fatigue, but finding it challenging in those rep ranges. So heavy weights. So I'll give you an example. I tend to like to progress people to doing a step up in a Smith machine, and then they are usually doing a step up in the Smith machine with approaching their body weight on the bar. So, and that's obviously over months, but they might start with 20 kilos and then get to 80 kilos of their body weight or something like that. Do you guys do kilos or pounds there in Canada?
A lot of my listeners are in the US, and I think they do pounds.
They do pounds,
in Canada, we usually do pounds, and in the UK, I think they do more kilograms.
Kilograms,
so it's all over the place.
Yeah.
Whatever you prefer.
Just double it.
Yeah, okay. So let's say for me, like the step up in the Smith machine. So I'll just describe so the listener knows what we're talking about. So a Smith machine is like a barbell that's held on to a cage it'll run up and down, so you don't have to balance, right? It'll just kind of slide up and down, and then you put the weights on the barbell. So what you're saying is you would put a step, like a regular kind of exercise step that you might get in a fitness class, and then you would put your foot on that, put the barbell on your back, and then sort of push yourself up to stand on the step. Is that right?
Yes, that's exactly right. Yeah.
And weight-wise, so for me, I don't know what I weigh in pounds. I weigh 80 kilograms, I think. I can't remember how many pounds that is. But I'd be looking to be able to do that with 80 kilograms on the bar. Is that right?
That's correct, yeah. Eventually, that's a good sort of goal for a recreational runner. Getting up to around about that level would be good.
Okay. And is that something that you would expect most people, like, is that, like, if I tried to do that now, would I be able to do it? Or do you find that when people do that, like, even if there's nothing wrong with them, that's really quite a challenge for them?
That's right. It's often still a challenge. So this is the interesting thing with things like these conditions. They are multifactorial in why people get them. It's not just about loading and getting weak, and a lot of the evidence suggests that strength is probably a factor, but it may even be something that develops as a weakness after you've got the problem rather than as a key risk factor. But we know that there are genetic predispositions for this problem. There are as we mentioned already, past injury, other injuries can predispose to it. So it is multifactorial. And training is a big one as well. But not everyone that overtrains is going to get a patella tendon problem. So there's obviously other things as well. And that's why you need to get assessed and be able to identify what might be the cause. And then you can, try and address some of those. Sometimes it is just things like people getting a little bit older, carrying a little bit more weight. Things like that as well when they're running. So and age itself is a risk factor because it will reduce the tendon's capacity to adapt to these types of running loads. So so it is multifactorial, and a lot of people that are, going back to your question, a lot of people that are maybe not so strong still are able to get away with it. Don't get any problems, and you look at them. You look at them in that sort of capacity, and they probably, a lot of runners don't like doing gym work because they like to run, and so a lot, and a lot are fine and they get away with it, but some probably don't, and that's the ones that we tend to see.
Yeah, I think that's something working as a physio that's come up repeatedly for me over the years, is that when you get someone with a tendon problem, they're not necessarily all that weak. Often they're stronger than other people, like who are doing the same things as them, whose tendons don't hurt. So like you said, it's not unfortunately that simple, where you just get them to do a given test and you're like, oh, look how weak you are. Let's fix that.
Yeah.
But the strange thing and the difficult thing I found about selling loading as a solution, because like you said, that seems to be where the evidence goes, is they're like, well, I'm not weak. I'm stronger on that leg. I can do more reps on that leg. And why is my tendon hurting there? And why would making it stronger help if it didn't start hurting because it was weak in the first place? And I've never felt like I had a really good answer for that.
The only good answer to that, I come across that all the time. So in the clinic, you'll see people, I think you can divide people into ones that have an obvious weakness and ones that don't. And as you say, there's a big group of them that don't actually, are not weak. Now, loading still is possibly beneficial for them because they will, the more you strengthen, the more the tendon gets theoretically stronger, the more it'll be able to cope with loading. So from that point of view, you can argue that regardless of what has given this to you, it could be that it wasn't strength, it was other factors, but still, even though you are pretty strong compared to your peers, doing some loading will probably help you because some of these risk factors we might not even know about. They might be unknown or we can't address them, like age. So we just have to work with what we can.
Then,
yeah.
Right. So the solution remains purportedly the same, or at least the first strategy would be, okay, let's do loading like the exercises you described and see how that's going. And you mentioned 3 or 4 months. Now I can imagine if someone's like, I have to do these exercises for 3 or 4 months, that's a bit of, you got to be able to sell that. Like, will they expect to see improvements within a few weeks, or does it really take like 3 months to start to see it to get better even?
I think that it usually takes a good few weeks for pain to improve. That's what I say to people. It's going to take a good few weeks for the pain to improve. So yeah, I think that is realistic. But I think the thing to stress, which we probably haven't talked about enough, is it's not just an approach of just give them some exercise and see how they go and it's the same for everyone. It does need to be very, very individualized. So, for example, we do also, the key thing that the other treatment that we probably haven't mentioned so far is education. So educating people about, a safe level of loading, how they should modify their activities, how they should get back to their activities, how they should progress. Those things are very important. Educating people about pain and how much pain is acceptable is also very important. So I think my impression is that some people will just get better just with that, if they can implement that with some support. Other people will need exercise because they've got clear weaknesses. Other people might benefit from exercise because they just need to adapt and get even stronger than what they are already. So there's a whole range of other factors. And then you've got other contributing factors like the weight that we've talked about, previous injuries that you might need to target. You mentioned earlier some people are weaker on the opposite leg, which is something I find as well. And maybe you need to load that because there's been a past history of injury of that opposite leg. So there's a whole range of individualization that we can do when we see people.
Yeah, that's it's funny. Recently, I moved to do a sort of hybrid physio coaching thing, and the main reason was that with runners, I find the most important thing to get right is their training. And if you don't get their training right, it almost didn't seem to matter how specific I was with their loading program, whether it's the patella or the Achilles or the hamstring or whatever. It's like unless I'm really quite deliberate about identifying what kind of runs bother this, what kind of weekly mileage bothered this, how many days in a row did you not tolerate 2 a days? Like, what are the things in your training that led to it? And I think you're right, we did kind of skim over that at the start and jumped straight into loading, whereas the biggest loading I would expect that their tendon is experiencing is actually from the running that they're doing. So you have to control that.
Absolutely agree. It's a really, really important part of it.
Is this a problem that we can prevent? Can we stop people from developing this problem?
I think if you follow the principles of just very, very sensible loading, you probably can, to some extent, prevent it from happening if you're very, very careful with how you load people. Weight is probably, BMI is probably a factor, especially as people get older. Um, um, and yeah, the other big one is sensible loading. Things like stretching don't seem to make much of a difference. Possibly strengthening, some form of strengthening could be recommended for runners where they keep their ability to load and their strength up, especially as we age, because obviously sarcopenia, i.e. reduction in muscle strength and bulk as you get older, and also the tendon gets less stiff as you get older, which then increases the risk of these types of injuries.
So, aging, the nemesis that it is going to make things harder. So, is it more likely in older runners? So, let's say 40 plus, it's more likely to develop in that population?
Yeah, I think so. I think it is. Yeah. Yeah.
And then, I heard something recently. I was listening to, I think Brody Sharp. I think I heard you on his podcast before, and he was talking about this study where they looked at females and found that their tendons weren't responding the way they would expect to loading. I don't know if you heard about that or if this is something that's familiar to you, but it was brand new to me. Is this a different problem between men and women?
I don't know the study you're talking about in particular, but there are differences in adaptation between men and women, but I don't think they're that great. You can still, yeah, there's more similarities for sure than there are differences. You can still adapt and get stronger as a male, as a male or female, but there are differences, and that's because of female and male sex hormones.
So we would expect slight differences in response, but we wouldn't approach this problem differently.
No, you
really,
probably,
if we had it.
Pain-wise, there's probably not much difference, but from a tendon adaptation, there might be differences in the length of time for some people, for some females, depending on balance of sex hormones.
Right. Okay. And you mentioned some other options. So we've talked about managing training load and how that impacts the development of this problem and how to address it. We've also talked about strength training, right? So, or loading and how you would approach that. But then you mentioned that there are some other treatments that you said had a little bit less evidence. So things like Shockwave and some injection therapies. Could you talk a little bit about what the options are on that front and whether any of them are really worth considering at this point in time?
Yeah, so Shockwave, the evidence is very mixed. So some studies show that it works, some studies shows that it doesn't work. It's probably quite similar for things like injections. So there's probably two main injections. One is steroid injections, and they basically are anti-inflammatory injections trying to reduce inflammation and pain. They do work, but they tend to work only in the short term, and then the pain comes back. And then the other injection is called a platelet-rich plasma, or PRP injection. And now this is sort of regenerative medicine where they take blood and they concentrate the platelets and they inject it into the tendon, and it's supposed to have some healing effect on the tendon. And the theory is really, really appealing, but unfortunately the science and the trials show that it actually doesn't work. It just flat out does not work. Right. So I would warn against, I would definitely suggest that people look at the evidence. Now, that's not to say it's still not part of the process, because it is safe. And with any intervention, you look at the harm versus the benefit. The harm is not at all there. The benefit, according to these trials, is not there either. but at least it's not harmful. And anecdotally, some people do get a response. So, it's still used, it's still popular. And especially I think in the US, it's quite popular. So, it is still popular. It's just that the high quality trials show it doesn't work. And that's a group effect, obviously. That's overall, you're probably not going to get much benefit from it. So yeah, the injections are not really that convincing at the moment. There's also, anti-inflammatories is another thing that some people take it, especially when it's sort of very, very. I think you can rationalize them better when it's like a real increase in your pain, a sudden increase in your pain. That's when you might take anti-inflammatories. There's also surgery, but that is really uncommon these days. It used to be quite common, but not many people have the surgery these days because, again, the evidence, it just doesn't seem to work very well. And we know we can get people better with the active approaches that we've talked about already.
So you would say surgery is pretty much a no by the sounds of it. PRP is, it sounds like you're being diplomatic, but it's pretty much a no, that the jury is in and the studies have been done. I suppose that one is an easier one you can do a placebo quite well. So is that why we've got the high quality evidence? Because we can give them a placebo and we say like it just doesn't work.
Yeah.
Right.
I would say I'm being more pragmatic than diplomatic because
Okay.
working with patients that are difficult, you do need to offer something at some point.
Right. So it's like
if you're
I've
working with
done
a
all
patient,
the stuff. Yeah.
Exactly. You've just got to, it's also good in a patient-centered way to be able to say, look, the evidence is not convincing. Some people do get benefit, but on a group level, it doesn't seem to be different to, say, placebo. It's up to you. It's safe. It's not going to hurt you. It's up to you. You've been doing rehab for a year. You've got minimal benefits. It's up to you. So I tend to just leave it to patients to decide.
Yeah. So I'm not as good at interpreting research as you, obviously. So when you say group effect, like, could that mean that there are people who will respond, like actually benefit from PRP? There's so many people who don't that when you do a trial, they kind of get swept up in it? Or are we pretty sure that it just doesn't work,
No,
for anyone?
we're pretty sure it doesn't work with the inclusion exclusion criteria in those trials, and that is usually people that, well, they tends to vary a bit, but it's usually a broad spectrum of people with Patellar Tendinopathy. It doesn't, or Achilles tendinopathy, whatever it is, it doesn't work for those people. But there's always the argument, oh, what about people who, have this characteristic or that characteristic, or have more severe, or have failed everything else, or as a second line or third line treatment. So those trials don't
Okay.
answer those questions because they're not powered to answer those questions. So, but there's always those arguments. Now, I think those arguments, I don't know how likely or plausible they are. I wouldn't like to say, but we can just be certain about the overall group effect is not there. But there's always going to be appeals to other underlying subgroups that might benefit.
Okay. Now you mentioned corticosteroid injections as well. So you said that they may have a beneficial effect in the short term, but that it'll probably go back to how it was. And my understanding that there is a risk to doing that, injecting into tendons. Am I right in that understanding? And what are the pros and cons for that kind of injection?
Yeah, you're absolutely right. It's sort of really an unwritten rule that you never inject into a tendon with steroid because there's a risk of rupture. There's a risk of damage and rupture. But injecting around a tendon is pretty common and pretty okay and accepted. I
Okay.
shouldn't say accepted. It's very, very debated actually, but it's the one that people do. If you're going to inject it's always around rather than into a tendon. It's the one that still gets done, but there are people, it does polarize people. Some people say you should never do it. Other people say it's completely fine. But certainly I've seen ruptures in young, otherwise healthy runners, athletes, when they inject into a tendon. So I don't think that's a good idea at all. But injecting around a tendon, I haven't seen it. I haven't seen as much of a anecdotal impact, i.e. rupture, after doing injections around a tendon. I'm sure they probably have happened, but I personally haven't seen. There's not any clear example where the injection around a tendon has caused that.
So when you say around, you're sort of injecting in the tissue nearby, and it's sort of bathing the tendon in the fluid. Is that what's going on?
Yeah. So for example, into the tendon paratenon, if there is one, depending on the tendon, into the interface between the tendon and the fat pad is a common place to inject. So that's generally where people inject. Yeah, it's usually just at the site where there's a lot of pain around the tendon. There's also so that's generally where they would go.
So that sort of outlines the risks quite well. What about the benefits of doing? Is this something that you use as part of your management, or is this something that you think is a little fringe now?
I always have that referral to a sports doctor / radiologist for an opinion regarding an injection, if as a backup after a few months of rehabilitation, if we're still struggling, or at some point. So that's it. I think it's a reasonable thing to consider, but yeah, it is gonna be something that you try and avoid as much as you possibly can. Put it
Right.
that way.
Okay.
Yeah, try and avoid it
some,
as much as you can.
So there's some other treatments that, clients often suggest, things like foam rolling, stretching, things like that. Either they've been given them or they've looked them up online. Like, does that kind of stuff help with this problem?
Not a great deal. I think some people can get short-term benefit from things like, foam rolling, but and also with massage and things like that, but it's not going to generally, for most people, fix the problem.
Okay. Well, that's a nice, easy one. I think we can end on that one because that was the easiest question.
Fantastic.
So thank you for joining us, Professor Malliares. If people want to learn a little more from you and look you up, where would be a good place to find you?
So I have got a website which is tendinopathy.rehab.com, and on that website I've got a blog which I talk about various things. I do a podcast. I've also got a course which is on tendinopathy, an education course mainly for clinicians, but for patients I do telehealth appointments as well, and you can contact me via that website, which is tendinopathy.rehab.com.
Cool. Is that limited to people within Australia?
No, it's everywhere. Yep, I see people
Nice.
in the States, I see people in the UK, all over Australia as well. Yeah.
Fantastic.
Yeah. So it is good. It is good. I enjoy it. It's often people who have had a bit of a run around.
Yes.
And yeah, so it's good to be able to help people.
I will put links in the show notes to all of those things. And certainly for the clinicians who listen, the podcast that you do is excellent. And I think Monash University have a podcast that you're involved with as well. Is that right?
Yeah, we do one with our students. Yeah, as well.
Yeah. So I'll put links to both of those in the show notes, and a link to your telehealth appointments for any clients who are struggling and not getting anywhere, who want a second opinion from an expert. I think that's awesome. So
Fantastic.
thank you for making the time to talk with us. It was wonderful.
Yeah, no, thank you very much. Thanks for having me, Matt. Thanks
I'll just hit stop on the recording there.